Hi, everyone, and welcome back to MedLink Global Runs. I am Ren Yang, CEO of MedLink Global. Today, we're doing something I've been really looking forward to. I'm joined by two remarkable leaders in psychiatry, Dr. Stefan Stahl, chairman of the Neuroscience Education Institute and professor at UC San Diego. It's great to meet you, Dr. Stahl.
Well, hello, good to meet you too.
Thanks. And Dr. Christoph Correll, professor of psychiatry at the Zucker School of Medicine and Charité in Berlin, and someone I'm lucky to work with at MedLink as a chief medical officer here. So today we're going to walk through 5 real-world patient cases. We ran each of these cases through Comentra, our clinical intelligence solution, and to see how the AI synthesize complex chart histories and suggest treatment pathways. Then we hand it back to Dr. Stahl and the Dr. Correll to see if they would what they would do if they're the treating psychiatrists for those complex cases. Before we unpack today's clinical cases, I want to give a few minutes to share to the audience what we built at MedLink. In everyday practice in psychiatry today in the US, the charts are huge and messy and fragmented, and clinicians do not have time to deeply listen to the patient and to listen to their whole story. So instead, they're expected to review hundreds of pages of unstructured EHR notes and track complex drug trials and spot hidden safety risks. All of these are usually happen today in the 15 to 20 minutes visit. That's why we're building this integrated clinical intelligence pipeline here from number one, the step one is the AI intake. Before the visits, patient will have a conversation like a phone call to share all the story of them, social history, psychiatric history, and why now, what brings them here today. The second is our proprietary psychopathology assessment co-built with Dr. Mark Blaze at Harvard Medicine that measures patient psychopathology severity and complexity. And last but not least is to synthesize everything together with years of EHR notes and history to give a treatment decision support. We call it Comentra as our treatment suggestion tool. And today's webinar will obviously focus on the step 3. Every case are already generated by Comentra for the treatment suggestion, and we will go through it. And about Comentra, rather than just a theoretical promise, we actually did a 12-month concordance study at a leading national health system. Christoph, you want to share a little bit more about the study? Please do.
Yes, so we wanted to put Comentra to the test, and what we did was a retrospective study in about 40,000 patients in this integrated health system. And what we did was we looked at what Comentra's output was and how much the clinicians in the past actually either did what Comentra recommended or did not do it. So that's like a concordance score that we got. And we followed patients from a decision point where something happened. They were just discharged, or the clinician made a medication change, or there were suicidal thoughts or whatever. And then we followed them 12 months forward. And what we found was that those clinicians that followed as closely as possible Comentra, their patients had significantly better outcome. They had better symptom reduction, better functioning, significantly so. They had less new onset suicidality, more remission of suicidality. They had less ER visits and hospitalizations. They had lower mortality rates, better functioning, and also lower cost, both in psychiatric and medical side. So that was pretty impressive. We're now repeating this because science lives on validation and repetition with another 40,000 patient cases in that same system. Now not locking it at 12 months, but leaving it open because some outcomes like mortality might even kick in later. But that suggests that the Comentra, which is a AI-powered clinician decision support system, not replacing doctors, but giving clinicians an idea, what could this diagnosis be? What are the potential ranges of treatments that are evidence-based? This is not modeled based on cases, what happened to them. This is evidence-based care, which hopefully can also become somewhat measurement-based care, because as you might mentioned, our AI intake collects data. We also want the PHQ-9, the GAD-7, maybe even a clinical global impression in there to feed Comentra and have even more precise recommendations for doctors.
Well, thank you so much. So now let's dive in.
So this is a 64-year-old single woman on disability presenting for new patient psychiatric evaluation after referral for possible attention deficit hyperactivity disorder. Okay, 64.
At the age of 64?
Well, it's most likely not onset, but continuation. The history also fits MDD, recurrent, severe with prominent comorbid generalized anxiety disorder, better than primary. Okay, this history better than primary ADHD. So she may come with complaints of inattention, but it seems to be more secondary to MDD and anxiety. So what are you talking about? Her attention difficulties are cognitive inefficiency, secondary to severe mood and anxiety symptoms. She endorses at least 7 of 9 borderline personality disorder features. In addition to that, screening severity is profound, PHQ-9 of 21. Well, that's really severe. And a GAD-7 also of 21. And a McLean BPD 7 out of 27. And she reports passive suicidal ideation without plan, intent, preparatory behavior, or current self-harm, but only passive. Firearm access is denied. Critical medication safety issue at intake. She has duplicate selective serotonin reuptake inhibitor therapy. She apparently is given both or prescribed escitalopram 20 and citalopram 20 also. So there may be a mistake or an error one would need to clarify with her. Also nortriptyline 50, and that creates serotonin syndrome and QT prolongation risk.
Who said that? That's ridiculous. That's ridiculous. Nortriptyline 50 with 2 SSRIs creates severe serotonin syndrome.
So that's their worry of the severe. It's what's written down. Concurrent temazepam 30 milligrams and nortriptyline add a heavy sedative and anticholinergic burden at the age of 64, likely contributing to cognitive complaints. Active stressors, as per the clinician, are housing insecurity, financial strain, disability, chronic arthritis pain, 8 out of 10, and volatile relationship with her children. She lives with her daughter, and prior treatment includes psychotherapy and ECT for whatever that was. Stopped in 2018, and we don't know when she was seen here in the past. And trials of fluoxetine, sertraline, and a brief Adderall course. Reasons for discontinuation are incomplete. So the clinician then diagnoses this with MDD, recurrent severe, GAD, then borderline personality disorder, and also ADHD is ruled out because it's more seen as secondary, and also rule out iatrogenic, sedative, anticholinergic cognitive impairment from temazepam, nortriptyline. Patient has also hypertension, hyperlipidemia, asthma, chronic arthritis, pain, 8 out of 10. Okay, so only passive suicidal ideation. There is this duplication of SSRI, the drug-drug interactions we've talked about, and some psychosocial stressors. All right, so complex case, 64, comes through the door, and this is what we read. The clinician synopsizes the case as. Any initial thoughts, Steve?
Well, I think that she's over-medicated, and I think obviously this may be mostly borderline personality disorder, and symptoms occurring when it's decompensating into anxiety, depressive kinds of symptoms. The idea of an iatrogenic sedative hypnotic cognitive impairment is a little rich, a little overstatement. I mean, 50 milligrams of a tricyclic is not going to give you anticholinergic problems. I'm not sure I like using them, and I don't like anticholinergics, that's for sure. But and temazepam is a very old-fashioned hypnotic that I don't use anymore. So I mean, I think that it just looks. Some of the language from whoever wrote this clinician is a little catastrophic to me. Serotonin syndrome is a mistaken term, because serotonin toxicity rarely occurs if you don't take an MAO inhibitor, and it can kill you. Okay, it makes your temperature go up to 106 degrees Fahrenheit. You have seizures and death. Okay, that's serotonin toxicity. This is not what this lady has. Serotonin toxicity, you could say, is diarrhea or anxiety from an SSRI. That's really kind of overstatement. So it is true that it's silly to give 2 SSRIs. It's silly to give too much serotonergic effect, and it could cause serotonin-related side effects. But in someone with borderline personality and who's in distress, it's very hard to interpret symptoms from medications. Is this another way of just expressing I'm in distress, or are these real symptoms? So, I mean, it would seem to me to stop a lot of the stuff, simplify the medications. Sometimes you almost want to go to the old-fashioned and erase the and almost stop everything and go from zero. But certainly you want to simplify things.
So it's interesting that you use the word catastrophic, because it's possible that the atmosphere in the room with this patient was catastrophic and the clinician was just infected by this and actually jumped on the bandwagon. There's, living insecurity, housing insecurity. She lives with her daughter, so maybe the daughter can't put up with her anymore. Now everything becomes unstable. She gets depressed, anxious, comes to the doctor to cry for help, so that the daughter takes her back or keeps her. So that there may be many, many psychosocial situations that also aggravate this. I wouldn't be surprised if the daughter would have accompanied her, but that doesn't say here in the note. Okay, let's see what Comentra comes up with.
So these are, because we're in focus view, it's all the actionables already included what we suggest.
All right, so that's the condenser. And so the agreement is that there is MDD both in the past. It's currently based on the PHQ-9 above 20 severe. GAD also, GAD was also in the more severe range, and borderline personality disorder. ADHD is ruled out, and also rule out. It needs to be ruled out. It's not taken for granted that there may be iatrogenic sedative anticholinergic impairment, and there is hypertension, hyperlipidemia, and so forth. So first, on the top, obviously, we need to see this patient might be dysregulated, might be crying for help even more, stepping it up. So again, suicide risk needs to be assessed because of the impulsivity and housing and financial stress on the pain. So basically, there needs to be a plan and a safety plan. Critical medication error, yes, we need to clean this up, this act, correct? SSRI, as you mentioned, needs to go down. We might want to even have an EKG if it's handy. Then we want to look whether we can simplify the sedatives, because is she not sleeping? Do we maybe add an antidepressant for sleep, like mirtazapine or something that can help her? What about that needs to be reconciled? Okay, then we have some metabolic panel, and we need to address the housing and financial stress-related issues, emotional dysregulation, the pain. Okay. Now, what is the this is a problem list, which is quite long, but what does Comentra now recommend we do?
So here it says, here's a problem, and then we should discontinue this. This is action. If we
and we want to deal with the psychosocial stressors, basically. That's it.
Right. Let me go to the comprehensive part and see treatment strategy. Basically, this is
this makes it easy. This is easier to read. Yes. Yeah. So basically, discontinue citalopram immediately makes sense. We keep the escitalopram because it's safer for QT. That makes sense. Here, the question is, do we need to step it up? The patient is really anxious, is depressed. Like the other case here, aripiprazole is offered as augmentation. It's approved. It's relatively safe. It doesn't have any QTC prolongation compared to placebo. Gives a nice slow start and taper, 2 milligrams, and then targets to stay 2 to 5, maybe go maximum 10 to 15, and then prioritize dialectical behavioral therapy for the.
So you're not going to stop the temazepam? You're not going to stop the nortriptyline?
So in this case, it was said that needs to be first ruled out and maybe find out. Let's see whether there are questions. Why are you getting the temazepam? Why are you getting the nortriptyline? That you're not stopping too much at once, but clearly this is something that needs to be addressed. I agree. So let's see what the questions are. When you experience sleep disturbance, could you describe in detail? So I think first we want more information. Is temazepam needed? Is nortriptyline for the pain needed? How effective does the PAM actually does help with the sleep? What about grogginess, daytime sedation? Do you experience distinct panic attacks? And long-term condition, personal goal in your life? Yeah, so I think more information was needed before making the next step, what to stop. 50 milligrams of nortriptyline is not that large. She has pain, which is 8 out of 10. So maybe that's why, at least in this first session, there weren't too many things to be addressed or done at the same time, but it's certainly something to also look at. I agree. In your experience, does duloxetine really have an edge for pain compared to SSRIs, or is that more like a lure? And would you also prescribe tricyclics for this more chronic pain-related issues, or even given non-steroidal anti-inflammatory if it's arthritis?
I don't think SSRIs work for pain myself. I do think that duloxetine does have a signal that's more robust than an SSRI myself. And I'm not sure nortriptyline is actually the favorite tricyclic. And it's funny, they tend to work at very low doses. I mean, low back pain, at least in the United States, is often treated with amitriptyline. And
Yes.
that's the favorite. I mean, something like 25 milligrams. So I think there is something about a tricyclic and something about duloxetine that's probably superior to an SSRI for pain. You know, when somebody says they're 8 to 10 of pain and they're in this much distress, I wonder whether or not the way to get their pain down is to treat their psychic distress so the appreciation of pain gets better and you don't really need an analgesic or certainly not an opioid. So I think in my you know, when somebody settles down, like you use the word and I use the word chaos, in a chaotic situation, you're in so much distress, even your body is screaming in distress. And when you settle things down, the pain tends to get better.
Good point. Yes, keep the body in mind and the mind in the body. So the sleep is certainly something to address. I mean, obviously in the first session, you can't do too many things. Let's first simplify the antidepressant regimen, understand what worked in the past. But if she can't sleep, that's obviously a problem. However, if the housing and financial difficulties are the main strain, we need to first get a handle on that and maybe also help her.
And something to consider, I mean, is do you want actually something more like pregabalin or gabapentin once you've cleaned up the temazepam and the tricyclic, because that could give you slow wave sleep. Slow wave sleep is actually pretty good for pain, and you know, and so is she really having trouble getting to sleep, or is she not having restorative sleep, or both?
Yeah, all very important questions to clarify. Okay, let's move on to the next case. So this is Priya. Let's see. This is a 23-year-old college student and assistant manager at a food service establishment presenting for initial psychiatric evaluation. So it's the first visit, apparently. She lives with a roommate, parents, sister, and roommate are her main, okay. She lives with a roommate, but parents, sister, and roommate are her main supports. I thought, woo, that's an interesting living situation. The principal driver of impairment is ADHD. Combined presentation, long-standing symptoms, a documented individualized education program in 4th and 5th grade for separate room reading and math, 2 college academic probations, and ongoing forgetfulness, distractibility, and task management difficulty. Mood and anxiety are comorbid, major depressive disorder, recurrent, now in partial remission, and generalized anxiety disorder in partial remission too. She's on sertraline 200 milligrams. PHQ-9 has trended down, going from 9 to 6 and is now 3. And GAD7 is now 2, coming down from 3 and 4 over 4 months. Mild residual symptoms. A medication-induced sleep disorder is present. So she has problems, nightmares from sertraline. I thought she had trouble falling asleep from maybe ADHD medication, but she has nightmares from sertraline, 200 milligrams, the upper dose for depression. And specific learning disorder, dyslexia, dyscalculia is also there. It's a rule out, stays open given the IEP history. A prior bupropion trial was stopped for irritability. Safety is low risk. She's non-suicidal self-injury or no suicidal ideation, homicidal ideation, no firearm access, and medical context, newly identified hypercholesterolemia, total cholesterol 239 and LDL 155, with positive family history, recurrent headaches and bruxism, all relevant to choosing stimulant versus non-stimulant ADHD treatment. She stopped psychotherapy in November, December, and is motivated to resume care. So we don't know. Can you go on the medication timeline whether since she's been on ADHD diagnosis since 4th and 5th grade, was she never ever on an stimulant? Doesn't seem to be the case. Okay, so only bupropion.
Right.
And she's on the contraceptive pill. Okay. All right. So the diagnosis is the established ADHD combined type. She seems to have the recurrent, but now partially remitted MDD, partially remitted GAD, and medication-induced sleep disorder, the nightmares. And one would have to rule out specific learning disability. And the question now is, what do we do? Any comments on the case, the formulation, the next step, Steve?
Well, it's about time we treated this lady. So in other words, it's about time we treated her. She has had no treatment.
Yes, yes.
It's ridiculous. You know, so it's one thing to start with a stimulant when you're an adult, and maybe we can consider whether that's the right thing now. But why she didn't get it, if you have an IEP and you have special ed and academic probation, all as a child and an adolescent, where was her stimulant, would be my question.
Yes, absolutely. Was she against it? Were the parents against it? Did the clinicians not see the need, or all unclear? Well, what are some of the questions does Comentra want to ask? Okay, given the history of ADHD traits, well, whether that's traits or whatever, way back to elementary school, what has prevented doctor from prescribing a stimulant? Okay, Comentra asked the same question. How do you feel overall about taking a daily medication for your focus? And are there specific worries or expectations you have about starting a stimulant like lisdexamfetamine? That's apparently what Comentra has in mind as the most efficacious and once-a-day dosing long-acting treatment for a college student. Can also not be crushed or abused, especially in college situations. This may be something that's at risk where people experiment, so that's not a bad idea. And when you experience racing thoughts before bed, can you describe them, what they are like? For instance, are you worrying about the next day? Is your mind just jumping rapidly between random ideas? So that's the idea. Is it rumination, or is it maybe pre-bipolarity because the patient was irritable on bupropion, which can increase dopamine, and maybe this person who had depression and ADHD could be at risk for bipolar disorder. So that's not a bad thought, Comentra, to bring that in, because that's often a disease trajectory. All right. Anything to add? Now let's see what the treatment strategies are. So as you said, let's start treating this patient at lisdexamfetamine and with a starting dose of 30 and target 30 to 70. Decrease sertraline downwards makes sense. She has only mild residual symptoms, but she has a sleep disorder. She has nightmares. So maybe this is just too much serotonin for her. And that is a great additional plan. Okay. Anything else you would want to add here? Steve?
My plan would be to probably continue to get rid of more sertraline. And my other plan would be to reinforce the fact that an adult should not get an immediate release stimulant, particularly as the first line treatment. I think that many adults that I don't believe their history, or I think they might be trying to get a stimulant out of me. I don't even try a stimulant first line. This lady already had bupropion, which might have been a good faith effort to try to avoid a stimulant. I don't know. But I think that in her case, I would use a stimulant first line, but it has to be a controlled release stimulant, just like this dexamphetamine. I think it's a good choice.
Great. Thank you.